Hi, and welcome back to the Cancering Show. We bring you this special edition because we felt that cancer patients needed important and unique information about the coronavirus outbreak and COVID-19. We wanted to bring you that information as soon as possible, and we're here in the studio today to give you as much information as we can about coronavirus and COVID-19, specifically related to cancer patients and cancer treatment. Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. Hi, and welcome back to The Cancering Show. I am delighted to have Dr. Jennifer Scalici, who's Chief of GYN Oncology at the USA Health Mitchell Cancer Institute, here today. So let's start off with what you're hearing from your patients, particularly those on treatment. What are you telling folks?
Well, first of all, this is an unprecedented situation that we find ourselves in. Fortunately, though, we are entering this unknown with the experience that Italy and China and some of these other places that have kind of gone through this have already kind of hit their peak, and we're getting a lot of information from those areas to try to base what we do. So fortunately for us, we do have at least some data or some guidance, if you will, to talk to all of our patients about what's happening.
So let's start by talking about what steps our health system and most health systems in the U.S. are taking at this point.
Absolutely. And this is really important. And I think MCI has been ahead of the curve on this, again, based on the experience from other places and the anticipation that we are going to have to deal with this. Our patients, we're all going to have to deal with this together. So at MCI, we have taken the initiative to have screening both over the phone and in person. So all patients that were coming in for a visit at MCI called and screened for symptoms. In addition to that, our practice has been such that we would call our patients who didn't necessarily have an essential need to come into the office. You know, we have patients that are on surveillance, in survivorship, who are doing really, really well, and the risk to them of coming into the clinic is much higher from a COVID standpoint than any benefit I could give them from a cancer standpoint, because they're doing very well. So we did contact those patients and let them know. Certainly we are happy to see them, you know, if there's any problem which warrants a visit, but if they're doing well, to lower their risk, we've asked that we reschedule their appointment indefinitely from 1 to 3 months out.
Absolutely. And you and I talked about this just even from a provider standpoint, but also from a patient standpoint. It's nice to know that the buildings are secure and symptom-free.
Exactly.
That a patient can come to the cancer center safely and expect that they will not encounter any symptomatic employees or patients at the cancer center.
Exactly. And that's the goal, is to make sure there is no overtly symptomatic patient sitting in the waiting room, visitor sitting in the waiting room. We have a visitor policy, 1 visitor per patient. Those visitors are also screened in person at the door. And again, the goal is to make sure that everybody feels comfortable, that everybody in the building absolutely has to be in the building. And it's an effort to protect both our patients and our staff, because we don't know how long this is going to last. We anticipate, we have a general idea, but we don't want to disrupt treatment. We want to continue offering the highest quality of cancer care that we can in the background of something that is very unknown. So as safe as we can keep people in the building, that these are the steps we've taken to do that.
Right. And just to clarify, you mean screening for symptoms, right? Not
Correct.
testing.
No. So unfortunately, at this point in time, we are unable to test everybody. That would be the goal. And that's what's happened in some other countries where you could just roll out a test, point of care, have an answer within hours to know who's positive and who's not. We don't have that luxury. So we screen for symptoms. Folks that screen negative are allowed in the building, and we go from there.
And what about patients who are sitting at home and positive for symptoms?
So the University Health System, USA Health System, has set up a testing site, which is drive-through. So if we call patients and anyone screens positive, we have a procedure wherein we can send them to actually get tested. And then until we have an answer on that test, we can hold allowing entry into the building and treatment and that kind of thing.
And just to clarify, those testing guidelines are very specific because of the limited number of tests that our cancer patients who are on treatment do qualify for testing. But someone who maybe has cold or flu symptoms without a known exposure or travel or any reason that they would be at high risk for a severe reaction to COVID-19 may not be recommended to be tested by their physician. And it depends on your personal medical history and the access to the test in your area.
Exactly. And I think, again, where we are right now in Mobile County without having a positive test or a positive patient at this point, it's hard to allow, testing for everybody.
Right.
Because those tests are still precious resources at this point.
And while you're all listening, just for clarification, if you are having symptoms, the recommendation is to stay home, stay indoors, self-quarantine, and call your doctor for further instructions, because most instructions after that will depend on your own health and medical history. So let's talk a little bit about surgery for cancer. A lot of cancer patients are calling to ask if their surgeries will still go on. The Surgeon General has put out a call to cancel all elective surgery. What does that mean for the cancer patient?
Well, first of all, elective is a really tough word because a hernia surgery that is being done because somebody is having an acute bowel obstruction, right, is different than a hernia surgery that is completely asymptomatic. So I think the appropriate term is how time sensitive and how urgent is that procedure. And when we're talking about cancer, a lot of our procedures are time sensitive. So at this point, any time sensitive surgery where treatments depend on completing those procedures in an expedient amount of time, we're going to continue to do that. Procedures where the urgency and the time-sensitive nature are not as imperative to do right now, because if you think about it, a patient coming through a hospital for surgery is exposed to 10 to 12 different individuals just in pre-op and getting to the operating room.
Absolutely.
So certainly we want to reduce exposures for patients where the urgency of that procedure is not as imperative to do it right now and has the capacity, we have the ability to push it off until we've hit the peak of whatever this is, and it's safer to do. There are some cases where we don't have that option, and we're going to continue at this point to do those time-sensitive, more urgent cases.
Absolutely.
Again, all of that really depends on what's going on in the community. And at this point in Mobile, there is no positive case. We are still technically at a minimal to no case level from the CDC mitigation standpoint. So nothing at this point has changed. However, we are cognizant of the fact that having personal protective equipment, PPE, that we use commonly in the OR, potentially those resources could become scarce. So I think amongst ourselves, we're being really careful about which procedures need to go and which procedures potentially can wait.
And it really is on a case-by-case basis. Even those cases that traditionally may seem elective, like, for example, a hernia surgery or a hip replacement, may really depend on your individual circumstances and your doctor's recommendation. So if you haven't called your surgeon to check on your surgery schedule, definitely do that because it's a discussion with the surgeon. While we're on the topic of having these types of discussions, tell me more about what's changed in telemedicine in the last week.
So what's the saying? Necessity is the mother of invention. I think that's where we are. It is necessary that we reduce risk. It is necessary that we socially distance ourselves. That doesn't mean we can't be creative and inventive in a really difficult time. So telemedicine, I think, is an advance that we absolutely need right now and probably can change the face of how we practice for the future. And it's really interesting. It's an opportunity to face-to-face with your doctor. And this is not new. For those of you out there who see other health systems, there are opportunities to do telemedicine in urgent cares and in family practices and that kind of thing. And I think we're trying to extend that now to cancer. So for our patients in surveillance, we can do a face-to-face and visually eyeball to eyeball see people, see how they're feeling. There are potential options to even upload data from activity trackers like Fitbits and iWatches and all that kind of stuff. So we're really trying to use the technology in front of us. We're socially distanced, but technology transcends that. So it's an opportunity to still, provide the level of care that we want to, still give a face-to-face, still have the empathy, the compassion, all the things that are great about a face-to-face doctor-patient relationship, and just put it on a screen for a little while. So hopefully later we'll have the opportunity to begin that. It's a very rudimentary, in a pinch setup for telemedicine, but I think it's the beginning of something that likely will grow and become more integral to what we do.
Yeah, no, I see this absolutely changing the face of medicine. Not dissimilar to other technologies, like you said, they can be very limited dissemination to early adopters until you have something big that really shifts the needle. And this will change telemedicine in the United States forever.
Absolutely.
That potentially every practice will go to offering you that option of not coming into the doctor. Now, we don't want to say that replaces the importance of a physical exam, for example, for a diagnosis of pneumonia and things like that. But there is a lot of technology out there that can help us. Even looking at you, we can say sick or not sick over the phone.
Exactly right.
And make those determinations of whether or not a patient could be directly admitted to the hospital, thus avoiding the cancer center and the emergency department where they could potentially become infected or infect someone else.
Exactly.
Let's shift and talk a little bit about immunotherapy. I know we talk about immunocompromise with chemotherapy patients and the risk that proposes to the COVID disease, but let's talk a little bit about how immunotherapy may impact a response to the coronavirus.
Absolutely. So you guys listening have seen the commercials on TV for a lot of these immunotherapies. Keytruda is one of them. So they're becoming more common and more widely used across a lot of disease sites. We use it as well in GYN oncology. And my counseling for patients who start immunotherapy is the concept, the idea behind immunotherapy is that we are taking the brakes off of the immune system to allow your immune system to fight back against the cancer. So, in doing so, when you turn on the immune system and turn the dial up to 11, the potential side effect is that everything becomes inflamed and irritated. You can get anything that ends in an itis. You can get arthritis, pleuritis, dermatitis, colitis, all of these itises.
Uveitis of the eyes.
There you go. Yeah. Any itis is a potential side effect. So when you know that something that inflames the lungs is a potential sequelae of the immunotherapy that you're on, it becomes really important to think about that when we are in the face of a disease where it appears that the biggest serious complication is inflammation of the lungs. So it becomes really hard to start a brand new immunotherapy in the face of a potential pandemic like this. So for our patients who are on immunotherapy and tolerating it well, I think we're going to continue forward as we are now. I think every treatment, there's a face-to-face discussion or at least a conversation over the phone about the potential risks at that point. I think it becomes really hard to start somebody on a brand new therapy that they've never tried before.
Particularly if there's another option.
Exactly right. So I think, it is a case-by-case discussion with the physician. We have to take into account other risk factors, other medical problems, what the cancer is, and really, is there another option that is safer at this point in time?
And we've talked in the setting of immunotherapy, but also in other disease sites about the benefit of clinical trials. Should patients continue to either pursue, or maybe the better word is to continue on a clinical trial that they're already on?
Right. I think continuing on makes sense, especially if they have been on the trial for a while, they're tolerating the therapy and not having any side effects or any complications whatsoever, I think we continue forward. Things we're doing from a clinical trial standpoint, typically there are visits from the sponsors of the trial come in and make sure that all the data is being collected appropriately and that kind of thing. And we have put a stop or a halt on some of those visits. We're still collecting the data. We're still communicating that data to the sponsors. We just don't have outside individuals coming in. I think for the most part, it's everybody's travel restricted anyway, but we certainly don't want to introduce new exposures to the building from outside of Mobile.
That makes sense. While we're on this topic of continuing therapy, talk to me about what patients do in a radiation setting.
It's a really good question. I don't know that there's a whole lot of guidance other than to say we know, at least from the GYN oncology literature, obviously with cervical cancer, once you start radiation, you want to finish radiation. And overall outcomes and survivals really depend on that.
And are it dependent on the amount of days it takes you to get to the end?
Exactly.
And so we want to keep it short.
Right. So from start to finish, we want to stay within the prescribed time period because people do better. So at this point, there's no plans to halt radiation. The benefit of radiation is that they're coming in every day and we can assess symptoms. And if there's any reason from either a COVID standpoint or any other reason we need to stop, we can. But we'd prefer to keep going. And at this point, the plan is to proceed, as planned, continue doing radiation, not interrupt it, and try to avoid that at all cost.
Great. Talk to me about maintenance therapy. There's a lot of patients out there who have had their adjuvant treatment and are on some type of maintenance therapy where they're used to coming into the doctor monthly. Do those patients need to come in?
So just for you guys listening out there, the adjuvant is the treatment after surgery, and the maintenance treatment is what you start after you finish your chemotherapy. And what we do, that is a pill. Which is great because you don't have to come in to have an infusion. It's a pill that you take, a couple of pills you take a couple of times a day. From maintenance standpoint, we do like to follow labs and symptoms. However, in these unprecedented times, I think it's very reasonable for patients to stay home, socially distance themselves. If they have any trouble, if they have anything they notice at all, we can bring them in and draw labs. But at this point, we're asking those patients to stay home and can keep in close contact with us to let us know how they're doing.
Great. And lastly, let's circle back to those patients in surveillance. Are they at higher risk for the COVID-19 if they've already finished all their treatments?
I think that's a really, really good question, and I don't know that we truly know the answer to that. There is one study that was done, I believe, from the Chinese experience that showed potentially anybody with a cancer history had a higher risk of more serious complications. Now, that sounds scary, but when you really kind of piece through the data, it was very small numbers of patients, I think 18 total. I think they were anywhere from actively getting treated to long-term history. Hard to know what those comorbidities were. So it's really hard to say that patients with a history of cancer are automatically going to do worse. I don't think we can say that. That said, if you have a history of any medical problem, it could be cancer, it could be a history of asthma or COPD or any of that, I think we know that if you've had any kind of medical problem before, the risk is probably a little bit higher. I don't know that that's truly specific to cancer.
And so let's wrap this up by saying, what is your recommendation to maybe a family member or friend who is worried about their risk for coronavirus?
So first things first, the CDC recommendations are stay home, socially distance yourself as much as you can. Wash your hands, 20 seconds using bar soap is probably the best. If you don't have antibacterial soap because it disappeared from the shelves of the Walmart, it's fine. Just use a big old bar of Dial soap. You're fine. And, just watch your exposures. My brother is a pediatrician up in Birmingham where there is community spread. And I think their mantra at this point is, hey, grandparents, it's time to visit the grandkids via FaceTime. Mm-hmm. Limit those exposures. If you have to be out and about 3 to 6 feet away from people, I know it's crazy. It's hard to even conceive of, but it's real. And I think we really need to be cognizant of that. Doesn't mean you have to cut yourself off from everybody. We're in a time where everybody's more socially connected than we ever have been, and take advantage of the technology, to connect, but take seriously those guidelines and those warnings.
Thanks so much for joining us today. I know you might still have questions. Please feel free to reach out to us on our Facebook page @Mitchell Cancer or on Twitter at USAMCI. The ACS, American Cancer Society, has its own website. CDC does have recommendations for patients with immunocompromise. Feel free to get yourself informed, and we look forward to hearing from you, and I'd be happy to answer all your questions.
Thanks, everyone, for listening to The Cancering Show with JYP, Dr. Jennifer Young-Pierce. Please subscribe, rate, and review this show on iTunes and anywhere else you listen to your favorite podcasts. Want us to deliver The Cancering Show to your email inbox? Contact us at cancering.com, and we can make sure you never miss an episode. We would love to know what you think about the show, or if you have any suggestions on topics you would like to hear. You can reach out to us on Facebook, Twitter, and cancering.com. Until next time, be healthy, happy, and always thriving.
This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond, with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.